I'll start by saying good day, everyone. I think we're live at this point. And Blake, I'll hand the first slides over to you.
Great. I think we'll, thanks, Amy. I think we'll wait just a few minutes. I see a lot of people joining, so it's like the numbers are climbing. So we'll give everyone just a minute to join. But good morning, good evening, good afternoon, everybody. We'll get started in just a minute once everybody's had a chance to join. I see the numbers quickly climbing. Okay, I think we have for everyone to join, and I'm sure a few people will keep joining as the time goes on. But good morning, good evening, good afternoon, everybody. Thank you for joining the February Global Digital Health Network meeting. And a big thank you to our hosts of the meeting, Pathfinder International. We're really excited to have the panelists here with us today to share their lessons of how, changes to service delivery and how they utilize digital technologies in the face of COVID and how they adapted them to the rapidly changing environment. So we're really excited for this presentation. There's not too much network business to handle this morning. Thank you all if you were able to join the Global Digital Health Forum in December. It was a really wonderful 3 days, and we thank you all for your participation. We know it was new for everyone to go virtual, but we think from what we've heard, it was a success. So thank you again. Stay tuned for updates. We do have our venue booked for the 2021 forum already in December. So stay tuned for updates on that. And I will turn it over to Amy and Blake to get us started this morning and this afternoon and evening. Thank you.
Great, thank you, Christina. And thanks everyone for joining the webinar today. My name's Blake Erhardt-Ohren, and I'm a MEL Technical Advisor at Pathfinder International, where I also serve as our representative on the GDHN Advisory Council, and I'll be introducing everyone today. So first off, we have Amy Ratcliffe. Amy is Pathfinder's Executive Director of Monitoring, Evaluation, and Learning, overseeing the global MEL staff. Amy has over 20 years of experience in public health, specializing in epidemiology, demography, program analytics, learning, and global health. Her experience informs her initiatives within Pathfinder to embed monitoring, evaluation, and learning into Pathfinder's DNA and increase the impact of our programs. Next, we have Norberto Banze. Norberto is a MEL Program Officer with Pathfinder Mozambique. Norberto is the Data Systems and Digital Health Manager and has lent his expertise to Pathfinder for over 7 years. Norberto has various certifications, including, but not limited to, ICT, data collection, data analysis, mobile phones for health, M&E, applications design, business management, and DHIS2. Then we have Lopamudra Paul. Lopa is the Director of Research and MEL for India's Yuva project at Pathfinder. She oversees routine project monitoring and evaluation, in addition to collaborating with external research and technology partners. Lopa works closely with the thematic area advisors in the MEL team, focusing on the design and implementation of operations research, rapid assessments, and program evaluations using both quantitative and qualitative methods. And last but not least, we have Akshay Gupta. And Akshay is a MEL and MIS officer in Pathfinder India, managing the DHIS2 data system used for the Yuva project in coordination with various consortium partners. Akshay also assists with Yuva project evaluations, such as baseline survey data collection and analyses of method mixes at health facilities. So over to you, Amy.
Thanks very much. I'll just do a very brief introduction for those of you that don't know Pathfinder. We felt like it was important to share Pathfinder's mission, which is to champion sexual and reproductive health and rights worldwide, mobilizing communities most in need to break through barriers and forge their own paths to a healthier future. So our focus is SRHR and an emphasis on gender empowerments and rights within that. Next slides. This gives you just a glimpse at the 2020 results that show the scale of our programs and the size, well, I suppose the breadth as well. So you see HIV counseling and testing, but predominantly our work is family planning, safe abortion, and youth in the work that we do with an emphasis. Next slide. And that we're active right now in 17 countries. So sharing this map so that you get a sense of where we are, which is Africa and South Asia. And I will now turn things over to Norberto. Thanks very much, Norberto. I will let you take it from here. And you will need to unmute.
Thank you, Amy. Well, I will talk about mCenas, but first I will be giving you information about Mozambique, which is the country where I live. Well, Mozambique has a population of 30.3 million people, 20.5 of whom are between 15 to 24 years of age. And this is the target population for the mCenas project, which I will be talking about today. 14.1 million individuals have mobile cellular subscription, which means that 47.7% of the population has access to cell phone. 10% of the population uses the internet. This number decreased from 2016 when the percentage of population using internet was 7.5%. This speaks to a need to use technology that does not require an internet connection. Next slide, please. Well, young people in Mozambique face a range of barriers to living healthy sexual and reproductive life, including social norms that do not accept their use of contraception and their lack of knowledge about the range of contraceptive methods. With this understanding, Pathfinder decided to innovate, developing an SMS-based solution named mCenas. mCenas is an interactive two-way SMS system to store narrative and resources, menus, and FAQs that is accessible at no cost for clients. mCenas it engages youth with SMS-based role model stories, in which characters are showing overcoming common barrier to contraceptive use, as well as a menu-based information message system. Since 2014, we have expanded from contraception in 2 provinces to topics across sexual and reproductive health, gender, HIV in 7 provinces, and late last year, we have added COVID messaging. Next slide, please. Well, stories are sent in installments via SMS over 2 months. The stories promote knowledge and awareness about sexual and reproductive health rights. And this information is also shared following the story sent via SMS, the sexual and reproductive health information, and contraceptive method menu and FAQs are available during the whole time while the project is being implemented. Next slide, please. It's important to note that there are 2 different ways to engage here. The first one is SMS messages pushed to youth. The story unfolds through messages that are delivered over 2 months. Every new story has a normal duration of 2 months. Story messages are sent 3 times a week for 8 weeks. One story for youth with children and another one for youth without children. Storylines have been divided into 24 chapters. Each chapter will with 160 characters in Portuguese, and we use first-person narrative style. And the second way is based on resources or menus they can access at any time during the implementation of the program. Next slide, please. The first confirmed case of COVID-19 in Mozambique was on March 25th last year, and as of February 1st, we had a cumulative of 39,460 confirmed cases and 290 deaths due to COVID-19. Next slide, please. Youth engagement provided an opportunity to reach in remote areas with COVID information. We were able to establish this at no cost to the client. We provided linking clients to MOH system so that information could be provided and clients could be referred and information could be gathered. So we decided to create an SMS solution in response to the COVID under the existing mCenas program. Since many solutions in place require a smartphone in a scenario where only 10% of the population are internet users. So how exactly does mCenas work? Clients send SMS to the short code, which is 4040, with the keyword COVID, and this will trigger an SMS from the system welcoming the client and will ask the name, the age, the gender of the client. And in case you are not registered on the system, well, those are the three questions that you will have to answer. If you're already registered, you are directed, you will get an SMS directing you to the menu that is already available. And once you finish your registration, this will take you to a place where you will receive 2 messages, one for self-screening for COVID-19, and the second to learn about the disease. So the client will continue with the interaction depending on the chosen option. If during the interaction, the client sends an unrecognized message, the system will reply with a message with instruction. The short code is integrated with 3 mobile carriers here in country. We just have 3 currently, and with an SMS platform, which works as a server, managing all the interaction. So once the client has been registered, the system will always call by name. We have activated reverse billing on the code. With the reverse billing, clients don't pay for any SMS sent to this specific number, and the bill goes to Pathfinder. We have also a menu that consists of 17 questions, and because we can't have all the questions in just one single SMS, we have split it into 3 messages. Next slide, please. On self-screening, we have 10 questions that we ask: cough, nasal discharge, body ache, abstain, and some symptoms are more predictive of risk. The reporting of symptoms is used to put client into low, medium, or high risk for presence of infection. And some symptoms are weighted more than others based on the logarithm. So once the client starts with the interaction and keeps answering the questions, the system will calculate, and then by the end, it will tell if this client probably has more as risks or not. Next slide, please. So the mCenas application connects individuals to the MOH hotline. that provides them with more information so they can take necessary precautions against COVID-19 or seek a treatment if needed. The hotline is free, and in this hotline, on the hotline, they have clinical staff working to support the agents. And after the screening, depending on the result, they receive an SMS with contacts to which they can call for help. And we have three categories. Once once you go through the screening, you go to the finish. If you are low risk, if you are in a low risk of infection, you will just receive a messaging counseling to keep taking precaution to stay safe. If you are in medium risk of infection, so you will just receive a message saying that your symptoms are suggestive of COVID-19 infection, and you will be referred to the MOH hotline. The same will happen if you have high risk of infection. You will be referred to the MOH hotline. So the message that the client gets that symptoms indicate high likelihood of COVID infection. Next slide, please. Well, as success, we had a high level of interaction with the system. Engagement continued even more when we added the COVID-19 module, showing that it came in the opportune time. And linkage to the MOH hotline reinforces the Ministry of Health surveillance. And mCenas is a system that we can easily hand over to partners if needed. And has challenges. SMS responses are limited to pre-programmed questions or keywords, and we cannot track whether users opened message. And last but not least, sustainability is one also of our biggest challenges. As we know, all projects start and end. So this is what we have as success and challenges. Next slide, please. One of the main lessons that I want to share is that we cannot move away from SMS if we want to reach the most remote areas with limited access to internet. In terms of emergency, we must act fast. So existing platforms can be adapted to respond to specific emergencies. In this kind of intervention, users want to engage and interact with platform. We should invest a little bit more on the interaction and create partnerships with others to allow us to provide better information and have further reach. And another lesson that is not listed here is that we should not use abbreviation on this kind of intervention for youth. Initially, we use the abbreviation on message to save characters and imitate how most youth write. But then from the feedback that we got when reading some of the comments of clients reacting to the stories, they were saying that whoever was sending the message should go to school to learn how to write well. And since the target group is in a phase of learning to write correctly at school, so we had to remove the abbreviations on the message. Well, MOH and other organizations developed solutions that works on smartphone and with internet. So Pathfinder was able to contact harder to reach population in rural areas with limited internet. So despite the availability of more smartphones and broader internet access, it's important to think about those without access to these things and make sure our solutions reach the last mile. Next slide, please. Oh, I think, thank you. It's all from here. I will hand over to Amy.
And I will hand over to Lopamudra Paul and Akshay Gupta, who will take us to India. Thank you, Norberto.
Hi, thank you, Amy, and hello to everyone. I'm Lopamudra from India Pathfinder. So today we are going to discuss about our digital initiative which have taken under Yuba. Next slide, please. Before going to our talking about our initiative, I'd like to just to give a background of India, which is the second most populous country in the world with the 1.37 billion people, and 18% of them are age group of 15 to 24. This also given us an opportunity of having a 84% of people having a mobile phone subscription, and also 1 out of, you can say, that 3 people are having usage some kind of internet, and which has increased in the last 4 years by 12%. So looking at this opportunity, Yuba has also come up with based is the digital technology and the platform, and this program has been targeted to the age group of 15 to 24 years married couple. So next slide, please. So the main aim of the Yuba project is increase uptake of modern contraceptive among young married couple, the age group of 15 to 24, the women, their husbands. And also this has been done in the 10 districts in Bihar and Maharashtra, 2 states in India. So this particular model is based on an entrepreneurship model to reach this target audience, and also use this digital mobile technology to reinforce this lot of messages and counseling model to using this digital medium. So as I have already told that it has been spanned over 10 districts in 2 states in the country, targeting 1.2 million people in this age group, and this first-time parents and young married couples. This is funded by Bill and Melinda Gates Foundation for a 4-year project, which will be end in June 2022. Next slide, please. So when I have already talked about this target audience, which is very young, who are very young, and you can see that they have that access, and how there has been, we are Yuba basically targeting from the marriage, and then the pregnancy, first live birth, which could be the 1 child, could be twins or the triplets, then till the second live birth. So it's a pregnancy to the parenthood. It has been targeted this young people, and also their mother-in-law, who has been used as an influencer for their family planning behavior. This is also has been talked about to reaching them through the key intervention. It has been Yuba has basically taken up. That was in a group meeting, home visit for the counseling, in-person counseling, telephonic counseling, and using a very huge way the mobile messaging through a different kind of audio messaging, video messaging, and also SMS. So these are the intervention has been planned already in Yuba, and we are already doing some of them. Next slide, please. So beginning of that project, we have also done a segmentation analysis to understand the psychosocial behavior of our target audience on family planning, basically. So how the family planning, how these audience, our target population behave differently when they are put in some distinct characteristics of those segments. It has been divided into 5 segments with distinct characteristics. And during that particular assessment, we also have tried to understand their mobile phone usage. Because as I have already told, that we are using mobile phone as a medium to reach these population. So therefore, mobile phone access and their usability was another important aspect to look at it. So while looking at this slide, you can easily see the access to mobile phone is range from 69% to 87% between all the segments. And majority of them has been used the phone as to make a call. While some of the segments like segment 4 and segment 5, you can see that people are using text messages also, which is followed by music and listening music. So these are the characteristics we have understood for these segments of usage of the mobile phone. Apart from that, we also wanted to see that how the ability to using those phones to dialing the number, written the number, or access the contacts. Those was come out with a high for all the segments. However, the using of the applications when the people who are the owner of smartphone is also varies from one segment to the next. At this point of time, I would like to invite uh, Akshay Gupta to talk about the Yuva's adaptation for COVID.
Thank you, Lopa, for setting up a nice context of Yuva to all our audience. So I would like to take you to the further slides regarding COVID-19 situation in India. So India was hugely impacted due to COVID-19 with over a 10 million case since March 2020. It impacted all of the states in our country, and along with that, our project states of Maharashtra and Bihar were also affected, with Maharashtra recording around almost 20% of all the cases of COVID, and Bihar 2.4% of all the cases of COVID-19 pandemic. So in order to cope up with the situation, Government of India imposed a complete lockdown from end of the March till 31st of May. So if I talk about India, like there are almost over 10 million cases of COVID-19, but we have shown a great recovery of around 97%, more than 97% of recovery in India. So, and among our states, if I talk about our states, there is a huge difference between Maharashtra and Bihar. You can see the difference in the peaks of Maharashtra and Bihar. When Maharashtra was facing a crisis, like over 50,000 cases in a day. So this was the scenario in India among our two states. Next slide, please. Now, in my slides, I'll be discussing about how Yuva has adopted the pandemic and responded with a contingency plan in consultation with our consortium partners, and how we modified our activities and resumed our field implementation. As you can see, consumer mapping. Consumer mapping is designed under the project Yuva to get to know our beneficiaries initially, and we can link them into our project through their mobile numbers. We started our consumer mapping in November 2019, and we were like moving steadily till March 2020 until the COVID pandemic strikes. So you can see a drop down in month of March and April, where we had to withdraw all our field activities and following the government rules and regulations regarding COVID-19. So in response to that, in response to the lockdown situation, we quickly responded to the situation and consulted with our partners and came up with the solution of a shorter version of consumer mapping tool, which can be administered on a telephone call, where our clients can be involved and we can talk to them over a telephone call and getting them to know. So during this process, during the process of digital consumer mapping or a telephonic consumer mapping, we utilized and took help of field level health staff, our ASHA workers, our nurses in the village at a village level, for getting the phone numbers of our potential clients. And also we used snowballing method. Snowballing method was a referral method where we can identify our potential clients. So in the if I talk about the two graphs which I have which are displayed on the screen. So due to the lockdown, there was a complete drop off in the consumer mapping numbers, but we took a little earlier in Bihar because of the different context of those two states. Like Bihar was little less affected due to COVID-19 as compared to Maharashtra. Maharashtra took a peak in the month of October, and Bihar we already started in the month of May. Next slide, please. Yes, this is a very interesting slide, as this shows how Yuva project has used the opportunity of COVID-19 in project implementation. Telecounseling was not a new to Yuva project, and it was supposed to be introduced a year after of implementation, but due to COVID-19, we accelerated the process. it helped us to test the telecounseling concept earlier than it was planned. So at one point of time, when we introduced telecounseling, Bihar was performing both of the activities simultaneously, and telecounseling as well as in-person consumer mapping. As due to the COVID pandemic was getting worsened in Maharashtra, we never started with the in-person consumer telecounseling in Maharashtra till month of December. But now, when things are better, situations are under control, we are resuming back to the in-person consumer mapping and telecounseling that was planned in the project. So this was the context of our two project states in terms of a telecounseling map activity. Next slide, please. Training, this slide shows the impact of COVID-19 on our training pattern also. So training is an important aspect of any of the project where we need to train our field staff, our frontline warriors for implementing our project at a field level. So since till March 2020, it was a default training mode was adopted. It was face-to-face training where people were interacting with each other, seeing each other, doing the activities which were participatory in nature. But due to pandemic, we needed to adopt and modify our plans, and we need to create a training material which was more user friendly in terms of a digital method of training. So it took us a while to develop the training materials with our training partners, and we came up with the digital solution. We modified those two materials, digitalized it, created some interactive videos to show up the Yuva Corps for getting them trained. In the second picture, this is the story of during the COVID situation, post-COVID, not post-COVID, during the COVID situation. We also made them trained on using MS Teams, how to log in into MS Teams, how to attend the training, how to share their views. How these are all our field frontline warriors who are working into the field for the same purpose. So training was also planned in a digital mode in future in the Yuva project, but it was also introduced early due to COVID-19. With a quote, uh, the the change is the only constant. I would like to now switch to Lopamudra, who will take you through the various successes, challenges, and the lessons learned during our journey. Thank you.
Thank you, Akshay, for taking us through the journey of Yuva during the COVID period, which has been, the measures has been taken. So it has been told that I can say that already there are planned for using the digital medium to outreach to our target population. But what COVID has done, COVID has accelerated using as a catalyst to accelerate this particular process during this period. And Yuva has shown has a timely prepared contingency plan, and it's an immediate you can say, solve the immediate problems, and to show that we should not lose much time of our project time. So therefore, after this investment we have done, we can see that we have continued to grow our numbers to enrolling people through that digital medium use, like the telephonic mapping, and also reach them through the telecounseling. So these two things has been a successful during this period. Apart from that, also I would say that we have also established that all the content of the training and the SBCC content in a digital medium, and use the online platform to do that. It has been successfully done. But of course, there is every success also comes up with a lot of challenges on the way. So we have seen this, there are some delays, definitely. You have seen when we had started doing this consumer mapping telephonically, and then we have started the telecounseling. There are almost a 3 months period gap during this COVID period. Apart from that, also we have found it out that when we are doing this e-training, there are some knowledge when you're transferring the knowledge to the people from the conventional classroom training, or from switching over to the online training, to the differential in that people's digital literacy, it has been happened that knowledge has been transferred to people, the participants, but what has happened, skill has been not transferred as it has been expected. So those challenges also has been overcome by using the local resources. So people can get the hand holding. And this is also a big challenge for us to keep those field workers to be motivated, keep connected with them through this difficult period. Next slide, please. So at the end of this period, we have some lesson learned. We have understood that digital engagement is need very tailor-made, because the users, all the people who are using it, they are not equivalent for the digital literacy. So everybody is not equal. So in that case, you need a tailor-made users for the different set of people to the access and the skill. As well as also, as I have told in my beginning slides, that the people, 1 out of 5 people are not having probably the mobile phone access. So there we need also in-person outreach to reach those people for our program, where we are talking about the behavior change for family planning. But finally, we also understood that the flexibility, agility, or adaptation to the context is more important for a program. And COVID has given us that opportunity to see and test and trial that how flexible and adaptation this program can be, and to face this crisis at any scale. So here I would like to stop and Amy to take over. Thank you.
Thank you all very much. I want to open it up for questions. We have a few that have come in, and I want to just let everybody know on the in the audience that there are 2 ways you can submit questions. You can use either the Q&A function, which is at the bottom of your screen, or you can put directly into the chat. So I'm going to start with, oh goodness, I'm going to apologies if I get names wrong, but I'm going to go to Ishrat Hassan's message. Could you touch upon the impact in terms of decrease in COVID cases or public responses in terms of use of the phone for providing the information? So I think the question here is, what kind of response did you get, and were you able to track any of that? I would suspect that you haven't been able to actually track this to direct impact on COVID cases because the numbers have been so small in both of the cases. But how about you talk about maybe public response? And I'll go first to Mozambique, to Norberto. So just how was this received? What was the public response from this?
Thank you, Amy. Well, here in Mozambique, we had the government creating these digital solutions in response to COVID-19. And as Pathfinder also, we have developed this SMS solution. But what we could note that the information that was being generated in the first days by the systems, we used to share this information with the Ministry of Health, and they were considering this information. And also for those who have tested, I mean, not exactly tested positive, but those who had symptoms or likelihood of having symptoms of COVID-19, they could give special attention and call to those for a kind of follow-up thing. But in terms of the linkage and also the follow-up during the beginning of the pandemic, it was a bit difficult to maintain a communication with people from MOH because they were very busy developing tools, developing systems, and creating. It was really a very tough time for the people to work on the all necessary tools to face the pandemic. So this is what I would like to share about that.
Great. Lopa, rather than asking the same question of you, I'm going to stay with Norberto just for a little bit, if I may, because I'm seeing a lot of questions come in around the SMS capability. And I know that SMS is a particularly limited platform, and also that there are many different alternatives to that. So I'm just going to spend a few minutes on the SMS piece. And so, Norberto, I'm going to give you a question first from our colleague in Ghana. And this is about how you overcame the limited characterization in the mobile messaging. And so this is a little bit of a technical question. How could you use SMS to share stories with these limited characters? And then a specific question, did you integrate the IVR messaging to cater for low literate people? So if you, I'll follow up with another SMS question.
Okay, what we did, we have splitted the messages because we know that each message contains 160 characters. So we had to organize the messages in a way that each of them had 160 characters. And those messages were being sent 3 times a week. So they would receive one part of the story on one day, and another day they would receive another part of the stories, and this will keep on until the end of the story. We had to design the system in a way that the messages could be splitted in a situation where it's easy to follow and then understand, because otherwise you could have a message that has been cut and the client wouldn't have enough information. So it was going like a soap opera. When you are watching a soap opera, you don't watch it just one day. You have different parts that you keep seeing. So this is how we have designed it and structured. We were giving these clients different parts of the story each day. So regarding the IVR, we haven't integrated. We were just using SMS.
So I want to also touch upon the advantage that you saw with SMS over radio programming. And one of the questions I'm going to add to this, so I'll read the question the way that it was written. This is from Cliff Schmidt. Thank you for the excellent presentation. You mentioned the need for using SMS to reach the remote areas with limited internet. But for the stories that you delivered, did you consider radio programming? And I'm particularly curious to hear whether you considered radio versus SMS as it would be attractive to the users. So, and it's possible that you haven't considered radio, but what have you thought the advantages of SMS over the radio programming would be?
Well, mCenas is not a standalone project. We have also projects that are being implemented along with this program. So we have activities in the community, and some of those activities also include radio programs. And on radio programs, we have we touch about sexual and reproductive health, not as a story like the way we have it on mCenas, but we have radio programs that we address issues related with sexual and reproductive health and a little bit more. But well, we never thought on having these stories being transmitted on the radio, but we know that youth, they like to stay connected with mobile phone. They spend a lot of time exchanging messages, and some of them have smartphone, and so they have access to these social medias. So we wanted a way to reach youth, and we know that most of them wouldn't be just sitting on to listen to a radio, but if you send a message, even if the client doesn't see that message in that specific time that you send the message, but later during the day possibly will read this message. So that's why we have opted to invest in the SMS division instead of radio. But sure, as I told you, we have these the radio programs also that go along.
Great, thank you. I'm going to ask my next question of the team in India, and I'm specifically interested in how you address the knowledge gap. And so especially, I think I'm going to interpret this question from Chetan as being the knowledge gap among your users. And so you talked about the segmentation study, and I think the segmentation study was really very interesting. And so there's quite a variation across those 5 segments of both use of their phones and the ability to use their phones. So how are you promoting knowledge and use among that group?
Thank you, Amy. Yeah, this is one question which I would like to talk about it, that knowledge gap where we have talked, first part of it was basically about our field level workers who has been trained through that Microsoft Team platform from a classroom training to has been switched over to an e-platform to learn. So what has happened when you have this interface from a classroom conventional training to an interface to a Microsoft online platform, suddenly, of course, there is transforming the knowledge, the way you present, there was you can see that gap. And our pre and post of every training has a pre and post test, and it has been shown that it has a little bit of decline during we have started doing that using the Microsoft Team platform. So we have done for a refresher training course, and we have understood that they need some refresher training. So therefore, a refresher training has been also included in the curriculum to get over it, and also make it a necessary changes in that approach, make it more participatory and all, to understand people, to bridge this gap. Apart from that, when you are asking for this, usage of the phone, which is a segmentation study, has been very clearly has been mentioned that maximum people have an access to the phone, but we have also seen maximum people have been, majority of them have stopped actually uses to make the call. So when they are basically using it to make a call, and that followed by the text or listening music and so on and so forth. And all the ability to using is also to make the call, how they dial the number, if they can find it out the number in the contacts and all. So in this case also, I would like to add it up that we also have in Yuba is a community radio program, which can be used, dial a number, and you can also press and listen certain particular episodes and the programs related to Yuba messaging and all. So we have a partner called Grambani in India. We're working as a consortium partner with Yuba, who have been also used this mobile phone technology and using this community radio through that. So I would like to say, so basically to making a call, also leading you to that some of the information. So your ability to make a call has been used also as a medium, or I can say use an opportunity to reach the people. So we have also used that opportunity.
So there are many questions here. I want to make sure that I'm balancing them. I'm going to ask the next about costs. And so there's a question both around how hard it was to get clearance to make this shift and how this was funded. I think I'm going to roll the first 2 questions that are here from Olivia to ask kind of the same question to India and Mozambique rather than different questions. So the way I'm going to frame this question is, how hard was it for you to get funding, both for anything you needed to add or for shifts for specific tasks within your work? So obviously there were certain things that you were needing to negotiate with your funder that you would move to go and do. And I want to link this to Sari Poj's question around the aspect of the cost of the data use and the network coverage. And so as you're thinking about funding, was extended use of the network or data also an additional cost? So the question might possibly be, where were the costs that came? Were they about shifting activities, or were they about the digital aspect? And then how hard was it to get that clearance? I'll go with India first, and then I'll come and ask the same of Norberto, or we'll just transition. Norberto, you can just mute yourself when Lopa's done.
Yeah, so while looking at the cost or making the shift, yeah, definitely UBA was planned with use of huge part of the digital medium and digital technology. It has been already budgeted with a donor, but during this particular time, we also have reallocated the resources, and it was a really thankful to the donor to use the reallocation of the resources and putting the digital technology in the forefront and using them in a larger scale was definitely, it's now part of the contingency plan. When we have actually the COVID situation strikes, we have also prepared this contingency plan, and we have also weighed all those components so that how we can reallocate the complete budget and use this digital platform, which is right now very much needed when the mobility is restricted to reach our population. So we should not curtail our services. So we have done that part of it. But when you were talking about the data and all, every in India there is different sets of data plan and all, and in many cases that is useful. But in our project we still haven't done that costing thing yet. So we'll get back to you once we are doing this kind of costing things. Definitely.
Apologies. Norberto, do you want to speak to how you pivoted and how you kind of managed the cost shift or reallocation within your budget?
Okay. Well, this situation, this pandemic actually came while we were already implementing mCenas. So we already had budget on our projects to implement mCenas. What we did was just to adapt mCenas, including this module of COVID-19, and even from the MOH, we had the recommendation to engage community through COVID messaging first than any other area. So when we had these cases of COVID here in Mozambique, the Ministry of Health, so they met with the partners virtually, and they advised the partners to invest a little bit more on the pandemic to spread the message about the COVID and create innovative ways to send information, to provide information to those who actually need this information in order to fight the pandemic. So for us, in terms of the budget, we already had a budget. Sure that with this adaptation, what happened is that we had a high volume of messages coming in and out, and this had a significant decrease in terms of what we used to pay before the COVID-19. But one thing also that I noticed that during the first days of implementation of the COVID or any other system, you will have a lot of messages coming in and out because people are curious to know what you have in your system. They want to explore everything. And this is good because they learn more. Every time they connect with the system, they don't just limit to read the first 2 messages that they get, because also the system attracts them to learn more because they have a menu on their screen, and they can read the menu and just send the keyword or the number to get information about what they want to know. So we had a very good interaction on the system, and yeah, this was easy for us to integrate. And also because we're not just sending message about COVID. SMS was mCenas is linked with programs with sexual and reproductive health. So we kind of adapted also the message so that we don't just send COVID information, but also send message related with sexual and reproductive health and say, oh, we are during COVID, we are during pandemic, but you still need to, let's say, refill, to go to the health facility for refill, or you still have to protect yourself in order to avoid unwanted pregnancies. So we adapted the message in order to the situation that we were. That's it.
That's great. And you had already had it set up so that everything was billed back to the program so that users were not paying for their own use of these messages. Is that right?
Yes, the users are not paying for the use.
And
Even the hotline of the Ministry of Health is free. They don't pay, and we refer them also to the hotline to get more information, and especially those who probably have some symptoms. So we just refer them. These are the ones who actually every other partner are referring for help.
So there's a set of questions that I want to acknowledge, but I'm not sure how much we will be able to address, which is about the increased number of COVID cases and the impact that this has had on the revenue at hospitals. One thing that I want to call out is that it's been very important from the Pathfinder perspective to partner not just with other NGOs, but also to partner and support the ministry and the health facilities in the locations where we work. So local as well as national or state level health facilities. And I think the expectation there is that as we continue, for instance, referring people to the Ministry of Health hotline, we are complementing the services that are there already. I know that this doesn't really answer the question of how hospitals can adapt the digital to cope with the impact and balance the revenue. But one thing I would like to point out is the importance of ensuring that there's also local access during times of COVID, and that the digital can help refer people to the local providers who still need to be able to maintain a level of care. And so I want to just ask Lopa and Norberto if you have anything as last comments that you want to either add to that or others. We have about a minute or two left.
I just want one thing to add it up with this particular thing. It is not only for that when we say for the COVID precautions, or we have used some of our resources for COVID, we have also done for our field workers. We have made the insurance cover through our partners. So, you know, for this COVID thing, so the people who are engaged with our project, they should be protected during this period of time. So we are also helped. It is not nothing like, it's not the government, but it is our initiative or through the projects. We have also given that. So I would like to add it up that in this particular period.
Thank you. This has been a really great conversation. I really appreciate all the comments that have come in. I did not read Sari's comment, but I invite you all to read that, how they've made up for the loss of in-person contact. The last thing I want to do is share, Blake will post in the chat. We don't need to go to the slide, Blake, but to share the link. Pathfinder has a whole set of COVID briefs that we'd like you all to have access to. And those will be in, there's a link in the slides as our last slide that will get shared after this meeting. And so those will be posted on the site, and I will hand things over to Christina. Thank you all.
Hey, thank you, Amy. Thank you to all the panelists and to Pathfinder for organizing this really insightful event. And I'm really, thank you to the audience for all of your questions to help kind of really make this an engaging session. I know in this time, we're all in many, many virtual meetings, so we appreciate you spending your time with us today. So yes, just as a note, for those who weren't here at the beginning of the meeting, because I know we started right on time, this is the Global Digital Health Network monthly meeting, and this was our February meeting, although we will be having another one at the end of February just due to some timing. So please stay tuned for that. If you're interested in subscribing to the Global Digital Health Network, I will post the link to how to subscribe to our listserv in the chat. But yeah, I just want to thank again our panelists. Thank you to Amy and Blake for organizing, and I hope that everyone has a great rest of your day. I'm just going to post this link, and then we will adjourn. All right, and stay tuned for further updates from the network. Have a great one.
Thank you. Bye.
Bye, everybody.
Bye-bye.